Ready?
Okay. Well, good afternoon, everyone. Today is March 29, 2023, and it is 4:01 p.m. As a quorum of the committee is in attendance, I would like to call to order the meeting of the Central Health Budget and Finance Committee. As a reminder, some of our committee members may be also participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. Okay, so the first item of business is public communication. Members of the public who wish to make comments virtually during the public communication portion of the meeting must have registered with Central Health via the online forum or by telephone no later than 2:30 p.m. today. Yesenia, did anyone register to make comments for the Budget and Finance Committee?
Madam Chair, we do not have anyone signed up for public comment.
Thank you so much.
Thank you.
So with no comments, we're going to move forward to our committee agenda. The first item, we have review and approve the minutes of the February 22, 2023 meeting of the Budget and Finance Committee. Do I have a motion to approve? Yes, Mr. Manager McTwenty?
I move that we approve the minutes from the previous Budget and Finance Committee meeting.
Thank you. Manager Vallo does seconds. So all in favor?
All right.
Any opposed? Any abstentions? So with that, the item moves forward. Okay, thank you. Now agenda item number 2, receive updates on the preliminary January 2023 financial statements, including capital projects for Central Health and the Community Care Collaborative. I would like to call on Ms. Lisa Owens and Patty Bethick will be presenting. Thank you.
Good evening, Lisa Owens, Deputy CFO,
and Patty Bethick, Controller.
and we're going to start with Central Health tonight, and Patty's going to give you some highlights.
Right. Thanks. I know, I get to do it myself. Well, let's see. Yes, no, there we go. Do it up on my shoulder. Oh, these are so tiny. Sorry. That's the wrong page. Okay. All right, I'm going to start with the balance sheet. That's page 4 of the packet. We have a very strong current cash position at $535 million. And we have restricted for capital $111 million. And in the restricted TCHC LPPF cash, we are holding $46 million as a fiduciary for the LPPF fund. And our total assets are currently at $1.3 billion. Going to the next page. The liabilities. Our total current liabilities are at $70 million. And our total liabilities are $475 million. Our total net assets are at $788 million, giving us our total liabilities and net assets of $1.3 billion. And moving on to the sources and uses. Our total sources year to date are at $246.7 million. Of that, we have property tax year to date of $236 million, which is 82% of the adjusted tax levy for the year. As of February 28, we now have $276 million, which is 96% of the adjusted tax levy. We'll report on that more next month. Our total expenditures in healthcare delivery year to date are at $65 million. And our total administrative program expenditures are at $5.5 million. So our total uses for the year are at 71 million. And that gives us an excess of sources over uses of 175 million for the year. With that, I'm going to switch it over to Lisa. You help the. Oops, I keep going the wrong direction, sorry.
CCC. Are you gonna do that?
Do you want me to do CCC or did you want to do that?
We'll do that.
Okay.
Oops, okay. So for Central Health, we talked last month about reporting out on our major projects, where we have had the board approve major capital projects. So we're going to start including this information every month. This is as of January, like the financials. And we've gotten some feedback, so we'll be adding some dates into this and a little more information about which projects are funded by certificates of obligation versus reserves. But what we want to show you is the major capital projects that have been committed to and are underway. An estimate of the project expenses that have been incurred to date. Keep in mind, many of these projects take a year and a half, maybe 2 or 3 years, depending on the size of the project. And what available funding is remaining. And then I've tried to outline for you there as well. As you know, every year in the budget process, we do allocate some reserves. We appropriate them in the budget for cash funding of some of the projects, and also repairs and maintenance, other acquisitions, of smaller things that we may have going on. But we also have some certificate of obligation funding from a couple of years ago that is available for, as you will recall, Hornsby Bend, Dowell Valley, and the administrative and clinical services at the Hancock Center, which is just getting underway with our architect and an open construction RFQ. We're very excited. So this is just a highlight. We welcome any feedback or thoughts, but it gives you a highlight of the major projects. I would also just add, when we get into the budget, which is not that far from now, we'll see detailed information about all of the reserves, the entire package. And we have much more detailed conversations about the annual planning for those reserves in that process. Are there any questions about Central Health? Yes, Manager Bill.
Okay. On the Red River realignment, that's like finished, right?
It is wrapping up. And so it's wrapped up. And so this is as of January. But as we close out the project financially, which will leave it open for a while, then if there are remaining available funds, those would be reappropriated.
Great. That was my question.
Thank you for that question. I think moving forward, I would like, first of all, thanks for that slide. And I would like to get feedback from board members about if they feel they want to add something else to this slide moving forward. And we're going to add some dates and timelines. I think that would also help and answer Dr. Bell's question as well. Manager Shannon Jones.
I think it relates to what you just mentioned. Do you have a time frame on the clinical services and headquarter consolidation, when that might be completed? I know it's still in the planning, but do we have sort of a tentative timeline on it?
Yes, December of 2025. December 2025. Yes.
Okay, and that would include both the clinical and the administration headquarters.
Yes.
All right, thank you.
Thank you, Manager Jones. Manager Valdez.
Yes, first of all, thank you for the synopsis. With respect to the capital projects and the contractors, could you also let us know if there are any late, if any of the contractors are late in performing according to the timeline?
Yes, so as we bring real estate updates, as we have, in the past month, where we feel like there's contractor issues, we'll bring them up in that same way, in that same form. But yes, as they develop, we'll bring them up real time.
Okay, thank you.
Thank
And then with respect to our map population. The current map population, because I saw there was 2 million allocated, is that going to be, are we doing 6 months or 1 year? I'm sorry, thank you, Stephanie. Are we doing, have we moved the map eligibility to 1 year yet, or are we still at 6 months?
We are still at 6 months.
And when will we be moving to 1 year? Because I thought we had talked about this last year, that
Yes,
we were
we did.
going to be doing 1 year this year.
It is a strategic priority of this organization that has been endorsed and ratified by the board, but as per previous discussions with legal counsel, some of these issues are now formally part of the hospital payment discussions, but now touched by the litigation. And so we'll need to have that conversation again, which we're happy to keep bringing it back to this board as to the mechanisms why, but it needs to be under a different agenda item.
Well, I'd like to have that conversation quickly because, or at least know what it is that we need to do in order to accomplish that goal.
Understood.
Thank you.
Okay, anyone else? So are you all fine with this slide? Do you have any recommendations, or would you like to see anything else besides what we highlighted? This will be a standing slide moving forward. Yes, Manager Caldas.
I thought that, I don't know, maybe I misunderstood what Manager Jones asked, but I'd like to see estimated dates.
That will be included.
I thought
in the-
that's what he's.
Yeah,
said.
the iteration.
We had discussed adding
Approval date.
approval date. We could add estimated completion date.
Yes,
And then also adding the financing mechanism.
Thank you so much.
you mean the approval of the certificates of obligation?
No, just whether the project is cash,
Okay.
a cash funded project or a project that is funded with.
Okay.
certificates of obligation.
Yes, Manager Brinson.
Well, would it be too detailed if we asked for the days over or under timeline? Are they going timeline wise?
So I can I answer that? I don't, I think that's more of a real estate progress update. This is truly just a payment update. That it should reflect that, but there could be some things that might not be represented. It's just the percentage of dollars, depending on the timeline presented by the contractor. But we can certainly work with the team and figure out if there's anything that we could do to add that. I want to make sure that the construction timeline the dollars might start really slow, but they're making a lot of progress. So we want to make sure we synchronize that with real estate.
Thank you.
Okay, so we'll move on. Thank you.
Okay, before I move on to the CCC, I would like to we mentioned this, but I want to remind the board and acknowledge Patty and her team. We are converting our accounting software this month. And so we are presenting January today, and we'll continue to have February next month. But the reports are going to look different. We hope they're going to be a lot easier to read. We know they're going to be a lot easier to prepare. With any conversion, we are getting efficiencies and new tools. But I just wanted to acknowledge that and remind the board that we are in that conversion, and we appreciate your patience through that. So on the CCC, I'll just hit some highlights. The activities really are around investment income and some administrative costs. We do have total assets of 13 million as of January 31st in the CCC, predominantly cash. And then our AP payables or liabilities that we need to pay are just $304,000 with our deferred revenue at 9 million. And I'll remind you again that that is revenue we've already received for achieving DSRIP outcomes. But while they're under review, we would reserve them until the review has been completed by the state and their auditors. But we don't anticipate any challenges there. Total liabilities there at 9.3 million, and then our net assets at 3.6. As far as sources of uses, We do have other sources, which is investment income of $112,000. And healthcare delivery expenditures of approximately $375,000. So our total net assets again at $3.6 million. And those expenditures are primarily in healthcare delivery operations. With that, I will answer any questions.
Well, thank you so much. Appreciate it. And we're looking forward to the new updated reports. Well, I was reminded that any of the board members who wish to speak, make sure that your microphones are on at all times. So I believe that Manager Valdez had a question. You're there.
It turned green. I was waiting for the lights to turn green. I was paying attention to the Travis County Commissioners Court conversations on the mental and behavioral health projects that they are going to be working on in the future. Are we in communication with Integral Care to see how Central Health is going to interface with that? As far as monies are concerned, is there going to be a commitment that we have to make additional amounts of money that may need to go to Integral Care?
I can address that as it relates to a budget or a financial
Right.
presentation.
Right.
That's the agenda item that we're on. Madam Chair, if I may.
Yes, please.
Since the conversation specifically about have there been conversations but centering on the funding issue, there have been conversations all over town amongst everybody right now.
Yeah, that's
especially
right.
as it relates, and for good reason, because the diversion center is what is front and center, as well as some other substance use treatment. And so the short answer to the question is yes, there's been conversations, but those things haven't quite congealed yet to where I can tell you this is what I think the fiscal outlays, or in our case, what we're already doing and doing more of that are going to be brought to the table as a contributing resource
Thank
for
you.
all these areas. Yeah, thank you.
Thank you. So any further questions? If not, we can move forward with our third agenda item. And that is discuss and take appropriate action on a notice of intent to issue certificates of obligation to finance acquisition and construction or renovation of real property and related reimbursement resolution. For this item, Jeff Canodal, Lisa Owens, John Morgan, and Dr. Solso will be presenting. And I will also announce that the committee is convening closed session to discuss agenda item 3 under Texas Government Code 551.072, deliberation regarding real property, and Texas Government Code 551.071, and with consultation with attorney. So we are back from closed session. And we will move forward with a presentation by Lisa and Jeff. Thank you.
Thank you, Jeff Canodal and Lisa Owens. We'll do this presentation and we'll ask John Morgan to come help us a little bit into the presentation. So this item is, I'm going to the next one. So this item, the requested action is to two requests that we're making. One is to approve a resolution to intent to issue certificates of obligation in an amount not to exceed $100 million for the acquisition of facilities to be used for clinical space, medical respite, and other medical related activities. There are two properties involved. One is a contemplated real estate purchase in precinct 1. We are requesting certificates of obligation in the amount of $90,575,000. And secondly, is the renovation of a clinical facility that we are renovating, the Rosewood Zaragoza facility as a multi-specialty center in the amount of over $9 million. Excuse me, that's the first action. The second action is to approve a reimbursement resolution that enables Central Health to reimburse itself from any advanced expenditures that it has, eligible expenditures to reimburse itself from debt issuance proceeds. And so before we talk about some of the aspects of this transaction, we are requesting the issuance of debt. And as it relates to reserves, we have been building our reserves in anticipation of implementing our guidehouse, our healthcare strategic planning exercise with Guidehouse. The board has approved the first phase of that, which has been community input and identification of the gaps. We're currently in the second phase of that engagement. It's referred to a lot as OFSP, which is operational and financial sustainability planning. I think there have been some preliminary presentations related to that engagement, much more to come. But we're here to look at our reserve levels. I've done a chart that looks at our reserve levels over a 5-year period. And during that 5-year period, we are looking at what our drawdown of reserves are, specifically as it relates to future expenditures and a preliminary estimate. And I'm going to say those words again. And if I could say them in capital letters, I would say that. Preliminary estimate of what we think the implementation cost of the engagement, the health planning exercise would be over the next 5 years. And that's going to be a significant drawdown on our reserves. We're still in very preliminary stages, but from an estimate, again, preliminary estimate in capital letters, we anticipate that to be at least $200 million over that 5-year period. If you remember, the initial phase of the engagement identified significant gaps in our health system, and we are trying to understand operationally how we implement a process to fill those gaps, to address those gaps. And so that's been our reserve plan over the last several years. And again, much appreciation to the board and its foresight to develop the process to build the reserves to give us the capability and capacity to contemplate fixing those and addressing those gaps. What this chart does, it shows our drawdown of reserves over a 5-year period. And it's really only looking at 2 scenarios. So everything is constant except one thing, and it's how would we pay for this acquisition that we're talking about today. So the blue line is the reserve levels, the course of action that we're recommending, which is to issue debt that gives us a much smoother drawdown of reserves and retains us at a level. Remember, we have a targeted fiscal level of reserves that we try to maintain of days of cash on hand at 120 to 150 days of cash. And that's the kind of the green bar that runs across. As you see, we issued debt and drawdown reserves based on our estimates. We're still a little above our targeted days of cash on hand reserve levels that we would recommend that Central Health maintain over time. If we were to cash finance these acquisitions and renovations, you can see that we would fall below our targeted zone. Actually, we're out of the zone at the very end, year 5, 2028. So thus, this is kind of a little longer range way of looking at our reserve levels, what some of our plans are, our financing levels, and some of the analysis that we look at financially on, do we have the capacity to cash finance anything, or should we look at other funding sources? And so the recommendation that we're bringing forward to this committee and hopefully to the board is that we would issue debt related to these two projects. Next slide.
Okay, we wanted to provide a little bit of information about the taxpayer impact. We will be working through this summer in the budget process. However, thought it was important to kind of run some numbers based on last year's assessed values and tax rates. The debt service is a separate component of the tax rate. It is calculated based on what your debt payments are or would be. So we estimated what the debt payments would be, were the COs to be issued. And the impact is about $12.84 to the average homestead with a value of $427,000. We also wanted to share with you information we have shared in the past about our long-term debt being comparatively a lot less than the other hospital districts, with some of our hospital districts, as you know, own and operate hospitals, much larger facilities, but we still are at the current lowest level. Also, information will get updated in this year's budget process, but a reminder of where we fare compared to the tax rate compared to our partners or colleagues in other major cities. Again, this is from 22. However, we still maintain the lowest tax rate and a very small percentage of the overall tax bill in Travis County. And again, reminder that our healthcare district does not operate a hospital, which is a difference in that.
It is a significant.
Yeah. So one other thing we wanted to highlight about just the market right now and information that people are watching the market. We did get some information on the 10-year treasury note and its 50-year history. And so we are in a good position based on long-term history, although over the past several months and year, we have seen some changes in the market.
Yeah, so if I could add, so you might ask, wow, I hear interest rates are going up. Is this really a good time to issue debt? Well, when you look at a 50-year history, we're certainly at the lower end. You see to the far right that there's been an uptick in rates, but they're starting to go down slightly. The way that we look at this, I think rates now, this is kind of our benchmark of the rates that we would pay. Where this index is about at 3.8%. We would typically pay about what's called 150 basis points over this index, or 1.5%. So we're looking at, if we were to do something today, probably about 5.5% kind of interest cost related to the issuance of the debt. And again, that's higher than our last issue, but I would argue to say that the last issue that we had was at the lowest end of that 50-year history. So that's a pretty good track record that the board has approved issuing debts at really low rate periods.
So with that, we wanted to have Dr. Shalsha and John Morgan talk a little bit about the uses and the activities that the acquisition and the renovations would support. Thank you.
Afternoon. Thank you for your time. Don Morgan, I'm the Chief Operating Officer at Central Health, joined by Dr. Alan Schultz, our Chief Medical Officer. We're excited to talk to you a little bit about the planned scope of services for a new facility and some opportunities that we have at Central Health to really advance access to care to some of the highest need areas that we have.
Good afternoon, Chair. Good afternoon, Board of Managers. Previously, we had the opportunity to share information with you related to some of our clinical initiatives, some of our successes, and a lot of the opportunities for improvement or opportunities. And I'm going to start off specifically talking about respite. Over the past year, we have been able to gain access to about 10 respite beds, and this is through contractual means. Some of the successes and the lessons that we've learned, even though this is a very small cohort, is that for about 59 patients, 6 months prior to them being housed in a respite environment, they touched the ED and were hospitalized over 100 times. For 6 months following their stay within respite, we decreased their utilization between 75 and 90%. It's a small cohort, again, and it's early, but the successes for the improvements in quality of life and hopefully the longevity of life are really significant. 10 beds is way too few. Right now, we have 16 people on a wait list, and the referrals that we're accepting into respite are coming from healthcare for the homeless and skilled nursing facilities. We have not yet opened the door for referrals coming from the hospital, and that's where the majority of the referrals come from. In addition, we are utilizing some of our skilled nursing environments to house patients that would be more appropriate in a respite environment. And so we think looking and building towards 50-bed respite environment is actually a really conservative number. The potential to acquire these properties and do build out would take a giant step towards really creating opportunities for our patients and our communities to succeed. Some of the other stats that I wanted to share with you before I hand it off to John are that when we look at the patients that we've been working with over the past year, about 60% of them have transitioned out of respite too early, right? About 30% left after 30 days or so because the criteria or the regulations within that respite environment were just too stringent, or they were administratively discharged, which means that they broke rules. If we look a little deeper into that, about 80% of our patients have an addiction disorder, and the respite environments that exist today are so specific and have a bunch of rules and regulations, which makes sense for the organizations that we're contracting with. But when you're looking at the behavioral health diagnoses that our patients have, the addiction disorders that our patients have, and the physical needs that our patients have, we have to build an environment that actually allows more flexibility and the support services by which if a patient has an addiction disorder or uses, right, or drinks alcohol, if as we do this build out, we are able to build an acute detox environment for patients, we potentially could have them work within our detox environment and readmit them back to respite instead of losing them to care completely, as well as if we can build some of the addiction services into the environment. And so, you know, the properties that were shown to you, there was an environment for respite and there were environment for some of the support services. What our plan is to do this build out so that we really, from social determinants of health to addiction services to acute detox, you know, we can keep those patients engaged and really help them succeed. And I'm going to hand it off to John, who's going to talk about some of those other services.
Thank you, Dr. Schultz. So in addition to the core functions of medical respite and some of the substance use disorder treatment, we would also program a dedicated, dedicated medical clinic to serve those patients that are in the respite environment. We've been able to do that on a limited basis in the contracted environment that Dr. Schultz spoke to. But this would really allow us to scale up the capabilities that we're able to provide in terms of support for those individuals. It also provides us an opportunity to construct the wraparound services that often don't exist in our purchased service environment. So you think about case management, embedded behavioral health, specialty care, telemedicine services, having on-site physical therapy and occupational therapy, as well as some of the social services connections that our patients need, whether that's to housing, transportation assistance, other programs that really help them be successful as they discharge from our environment. I should mention that as a focus area for our direct practice of healthcare here at Central Health, this doesn't mean that we in any way stop working with contracted partners. We are continuing to work with multiple agencies to identify additional contracted respite beds. And to Dr. Schultz's point, some of those other contracted environments are more appropriate for specific subsets of our population. So this is about bringing additional tools and additional options to bear for our patients. Similarly, with substance use disorder treatment, continuing to work very closely with our partners at Integral Care and Community Care, with Dr. Oshbach's team and community medical services for methadone services. We're continuing to look at contracted options as well as building internal direct practice options for our patients.
So this is a lot of information, but just highlights what the events are that happen after today with the bond sale. It does start with today and our visit next week, potentially to the commissioner's court with a notice of intent. There's a lot of publication requirements which are listed. We do have a 45-day waiting period. We will have another look at our bond rating, which has traditionally been very good, and we anticipate maintaining that. And then we anticipate coming back in June with a request for the adoption of delegation of authority to our CEO to administer the sale and issuance of the certificates of obligation. And again, another visit to the commissioner's court. And again, closing and delivery then at the end of July. So with that, I'll go back to what Jeff started with. The action requested is the resolution of intent to issue certificates of obligations in the amount designated, as well as that reimbursement resolution, which enables us to use those funds were they to come in July to reimburse ourselves for any expenditures made prior to July. And with that, I think we'll answer any questions.
Okay, well, thank you so much. Appreciate it. I would like to take a motion first before we move forward with any discussions. I'm sorry.
Yeah, she's gonna take the.
I'm gonna take the motion, then we can. Correct. And also for the new board members, I want you to be aware with this committee, you can also make any votes in motion. So this committee, every single board member has a vote. So with that, would anyone want to entertain a motion? Manager Valdez?
I move that the committee recommend that the board adopt the resolution provided to board members earlier. I request A and B both.
Correct.
Okay. Requesting the Travis County Commission's board to publish notice of intent to issue certificate of obligation to be used for the purchase and renovation of medical clinics and patient support services in Northeast and East Central Travis County, and thank you. Authorizing the president and CEO to execute reimbursement statements on behalf of the district and any other documents necessary to carry out the purposes of the resolution, including completion of the resolution on behalf of the board to add any omitted information.
Thank you. May I have a second?
A second.
So I have a second. With that, do we have any discussion? So this is an opportunity to ask questions. So I'm going to start with Manager Kitchen.
first. And we'll go down.
Just a quick question about the motion. So item A relates to, I'm looking for the words medical respite in here. So maybe that's not necessary, but is it the reference to medical clinics and patient support services or?
Yes.
Is there a reason why we don't specify medical respite?
It's just a very broad category as it relates to the necessary language that we need to publish, so that we haven't gotten real specific on it.
Mhm.
We will as we develop our planning and uses for the facility.
The only reason I'm asking is I'm just, maybe asking legal to just verify for me. I mean, I know you've looked at this and everything, that the term medical clinics and patient support services would be extensive enough to cover the fact that folks are, they're staying there. In other words, it's, and then it won't be interpreted as housing that's not covered by this kind of CO.
So,
That's my question.
Let me, we've had bond counsel review this.
Oh, you have,
based
okay,
on
wrong
all
question, sorry.
purposes. Right, and so they felt like this language was broad enough for us to include what our plan purposes were for it.
Thank you.
does that answer your question?
Yeah, that answers.
Okay. Management one.
Yeah.
Is there, forgive the limitations associated maybe with my ignorance around finance here, but is there, the charts that we saw showing what cash reserves look like with debt versus cash financing were pretty compelling. And I'm still curious though, is there a reason that there isn't maybe a hybridized Goldilocks version, or is it because fixed costs associated with debt service or the fixed overhead associated with debt service doesn't make it worth it to do a half-lease kind of thing?
I was just gonna say, from a financing standpoint, we look at issuance costs. We look at just the aggregate. Is there something in between? And we feel like just from a pure debt financing standpoint, that it's appropriate to debt finance the entire amount, just to maintain the separate the reserve levels that we're comfortable with.
Well, then that makes even more sense. Thanks.
Manager Brunson.
So you are requesting the debt to be pretty much what you feel like it's going to take to cover the ideas now? Or have you sort of thought about inflation? Inflation has been so dramatic over the last year or two. Does that include perhaps the continuation of this inflammatory rate? That are we asking for enough money? Because you only want to do this probably one time.
Yes, thank you. I would certainly agree with that. Thank you for bringing that up. We have thought about inflation. We have I'll call it a healthy contingency. We have done our estimates based off most recent data. We're constructing clinics now. I think our team is really zeroed in on what today's costs are, and again have put a healthy contingency in the event we have either cost escalators or supply chain issues.
Thank you for that question. Thank you, Chair. Val.
Can I go to the graph, to the debt versus cash financing? When you look at the orange line, the cash financing, that's actually financing this particular project. And did you say it includes other things that we would be spending cash on, or does it exclude that?
So both lines are constant. The difference is that financing this real estate purchase or cash financing it at build. So really the delta in it is upfront. If we were to cash finance it, your outlay of cash will be about $90 million over the next 3 to 4 years, right? You acquire the property, renovate the property versus level debt service payments. The debt service payments would be over a 20-year period. So what we're contemplating on the debt issuance is for Rosewood Zaragoza, a 10-year term for the debt. If you guys remember, that's one of the clinics that the city conveyed as a low, let me just call it nominal leasing clinic. We currently have that lease through 2034. We're working with the city to extend the lease for at least another 10 years. But we haven't consummated that and executed it through city council yet. And so we're going to issue the Rosewood Zaragoza debt with a term of 10 years. The other significant debt issuance, the 90 million, is over a 20-year period. And what you see are just the debt service payments for that 5 years.
Okay.
So much less than the total cost of the whole project.
Okay. Which keeps us above our targeted days of cash.
Right, I think the debt service for both is around $7 million a year. So when you look at $7 million of debt service versus a instant outlay of almost $100 million in a 5-year period, that's a significant difference.
Got it. Thank you.
Thank you. Manager Valdez.
First of all, I would just want to follow up with Manager Kitchen. Is there a way that we could, for making people comfortable, because sometimes we don't always have access to what was discussed in backup materials as we have discussions, let's say 10 years from now. So I was wondering whether or not it would be possible to attach this or cite it for the record as referring to the ask and the resolution, or to actually state, quote, comma, including medical respite, comma, and then the rest of the motion. I was gonna, as the maker of the motion, I was gonna be willing to amend it to include that. Or just the other way, in the alternative, just citing the backup materials, which does include all of that.
All back, well, just by virtue of this conversation right here, we can put that in minutes or
Okay.
something to that effect to memorialize what you
Thank you.
just said. So that's done. But certainly I think, when the minutes come back for review for this committee, you all can look at those minutes and you can amend the minutes next time we present them to you to make sure that it's reflective of it. And we'll put a note on the meeting script notes so that we know to pause a moment on the minutes when they come back to you to make sure they reflect what you need them to say. And of course, all backup materials are included as part of the record for, whether they're presented in meeting or provided in advance.
Thank you.
Thank you.
And you don't have any questions? Manager Jones? Manager Martin? We can make it within 3 minutes.
So, how much would, so we're looking at 10 to 20 year bonds.
Your microphone.
It's on. So we have 10 to 20 year bonds, is that correct?
That's correct.
What is the total cost per dollar borrowed over the course of that bond for the people of Boston?
I think the total interest cost at 5.5% was about $60 million aggregately. So for every dollar you're borrowing, there's 60 cents in interest that you pay over the life of the debt.
Okay, thank you. Do we have any other sources of income to increase our cash reserves? I was just perusing things, for example, specialty services, pharmacy, etc., as one thing. Have those costs been reviewed to increase our revenue? So we have more cash on hand and not perhaps spending money that we don't really necessarily need to spend. I mean, I'm not part of this committee, so I'm just curious if those issues have been addressed. You are. Yes, you are.
Mr. Martin, patient service revenue?
Patient services, pharmacy acquisitions, things like that, that cost be constrained to increase the amount of cash available on hand.
So we are planning to enroll in both Medicare and Medicaid. And potentially also into some ACA products. And really Medicare primarily as it relates to dual eligible populations that, you know, is really aligned with Central Health's mission of who we serve. So there will be some revenue opportunity there. But really what we've understood from this board and from our strategic planning analysis is we have a long way to go in terms of the capacity needed just to serve our MAP and MAP basic patients. So we really want to focus and prioritize patient services over patient revenue opportunities, even though there will be some. The primary scenarios where I think we will have revenue opportunities is where someone enters our services as a MAP or MAP basic patient. And while they're in our care, we're helping with disability applications, with Medicare and Medicaid enrollment, with ACA enrollment, so that, you know, we can continue to treat that patient once they potentially convert to another source of coverage. But I think we expect that percentage overall is going to be relatively small, especially in the first few years. I would say certainly less than 20% of our overall patient mix, likely less than 10%.
Okay.
So not a lot of offsetting revenue from a patient revenue perspective. I do think we're also looking at opportunities for grant funding throughout our clinical service work. You know, that could be from private foundations, that could be through organizations like CPRIT that offer opportunities for services to be directly funded from external resources. But I think that will really offset costs on the operations side, certainly not as much on the capital side.
Yeah, I wish you had one thing, but I don't want to be remiss of it, is we're always looking for opportunities. If there are any Medicaid supplemental payment programs that we could participate in, that we would look at those opportunities also, which could be significant. So
Okay. Everyone, this question is for you, Glenn. It's when we, you know, the human cost aside, because I'm first and foremost a physician and I get that. When an admission goes to Del Seaton, say congestive heart failure, and they're uninsured or anything, who bears the cost of that admission to Del Seaton, to the ER visit, and the admission costs, the intensive care unit, et cetera?
So at a very high level, those costs are going to be borne through Medicaid supplemental payments and uncompensated care payments to the hospital if they're uninsured.
Which you go to the hospital.
Excuse me, Dr.
Yeah, that's correct.
Yes.
Right.
And but then, you know, even when you think about when that patient is discharged, you know, we have folks in the hospital right now that help to get people enrolled in MAP. And so it's not, you know, this is a doctor, you know, you have the hospital episode, if you will, but then with a lot of the follow-up and the transitions of care that Dr. Schultz has spoken to, we would then start funding that as part of that healthcare episode.
But as Dr. Schultz pointed out, ER visits were cut down 60 to 90%. That saved St. David's, Del Seaton, a lot of money. These are not admissions. These are people that are repeat visitors to the emergency room. So Central Health, by instituting these programs, is saving these medical systems money. Is that correct?
Mhm.
In light of that, is that a correct statement? Or no?
I would say for that individual patient, yes.
Well,
Yes.
90% of visits, and was in the ER doctor. In light of that, and this might be a totally different question, but as a source of working with them more coherently to sort of say, we're saving you money, bring money to us to the table to some extent, to increase cash revenues to some extent.
Yeah.
Well,
That's right.
Doctor, that is thank you for saying.
That's right.
And I mean, that's the obvious in the room, but it's, we've got an agenda item coming up at the board meeting where we can answer that very question.
I just.
But it is directly related to our hospital affiliation agreements and some of the current issues that we're
Right, paying essentially 70% over the course of a dollar that we borrow and kicking that can down the road. And costing the citizens lost quite a bit of money. I mean, I think it's wonderful, the respite and the stuff that's going to happen. But we're asking the citizens to bear a large cost. And I think that to consider any way to increase revenue from participating partners or costs, I'm sorry, I thought it was on, would be something I hope we could address.
Yes.
Thank you for that. Mike.
And I think in addition to that, I'd like to point back to the 5-year performance review that we had. This obviously predates you, but where it poses existential question when it comes to financing and actually, I'm sorry, it relates to financing the debt, but it poses an existential question with respect to how services are provided through partnerships and affiliations. And we can certainly get into this on a properly agenda item, but the essence of it is by taking these financial projections here and looking at debt versus cash financing and being very bold and deliberate and open about what it is that we're doing to provide for the MAP population and for those that are uninsured, living below 200% of federal poverty level, by stepping in and providing these services and having more direct influence over them. There's a trade-off here. Now the question is, can you put dollar value to that trade-off? I'm sure, Jeff, if you give him several days, lock him up and don't let him do much, you could probably come up with some kind of model to be able to do that. But there's, and this gets back to the germane report, and I'll defer to those board members that, we're privy to that, when we talk in this room openly about that report. I'm afraid there's some dollar amount that we can't put to that. So there's a trade-off in terms of controlling your own destiny versus being 100% dependent on the partnerships. So that's, I just want to put that out there because this came up in a different context about 5 years ago. But then back to your point, I think there's some things that we can certainly address in the upcoming agenda item with respect to what happens with the fiscal interplay between these different systems and what happens when we put dollars on the table that this board has approved and when we take on debt. Excellent question. We'd love to address it.
Thank you so much. I think overall, the aim is to improve the quality and the outcome of life. I think that's why we're here, and we're all committed to providing more services to those who need it. And this agenda pertains to that, providing more and a good, high quality care. So with that, we have a motion on the table and a second, and I call for a vote on this item. And as I mentioned, everyone is a member to this committee and everyone can vote. So all in favor? Any abstentions? Any nays? So the vote moves unanimously. Thank you so much, board members, for that. I'll move forward to our final agenda item. Yes, Ms. Valdez.
Before y'all leave, there were some slides that we did not get from the presentation. If you could please forward them to us, I appreciate it. Thank you.
Well noted. Thank you. So item number 4, confirm the next Budget and Finance Committee meeting date, time, and location. Managers, our next Central Health Budget and Finance Committee meeting will be held just before the February Board of Managers meeting at 4 p.m. on Wednesday, April 26, 2023 at Central Health headquarters, 1111 East Cesar Chavez, East Austin, Texas. At this time, I'm ready to accept a motion for adjournment.
Second.
All in favor?
Aye.
Aye. We're adjourned. Thank you.
Is 5:25 p.m. As the quorum of the committee is in attendance, I'd like to call to order the meeting of the Central Health Executive Committee. Public communication. We will receive public communication for both the Executive Committee and the Board of Managers meeting before we proceed to the executive committee meeting agenda. Members of the public who wish to make comments during the public communication portion of the meeting must have registered with Central Health via the online forum or by telephone no later than 2:30 p.m. today. Yersinia, did anyone register to make comments for either the executive committee meeting or the Board of Managers meeting?
No, Chair Bell, we do not have anyone signed up to speak.
Thank you very much, Yersinia.
Thank you.
We will now proceed to the executive committee agenda. Agenda item number 1, approve the minutes of the Central Health Executive Committee, February 22nd, 2023 meeting. Manager Brinson?
Second.
I have a motion from Manager Brinson. I have a second from Manager Valadez. Any further discussion? Hearing none, all in favor? Any opposed? Any abstaining? Motion carries. Agenda item number 2, review and provide direction to staff on the prioritization and tentative scheduling of items for consideration at future Central Health Board and committee meetings. Brianna Yanis will be presenting.
Okay, I will quickly go through the April tentative schedules.
Brianna?
Forgive me, did I hear January 29th?
No, she said February.
She said February, it was.
Did I say?
Oh, I thought I heard, the motion said January, I apologize, we were trying to correct it, but, okay, so but is it material? Okay, thanks.
She
Thanks.
said before the April board meeting.
Yeah.
It's not the way I do it.
Go ahead, Brianna.
Okay, so I'll start with Eastern Crescent and strategic planning. For Eastern Crescent, right now we just have minutes on there. For strategic planning, we have our minutes, Central Health fiscal year 22 annual report, quarterly enrollment and utilization dashboard update, an update on Central Health annual quality of life and patient experience surveys, FY23 service delivery budget priority update, and a Q2 fiscal and operational update from CUC and Sendero. For budget and finance, we have minutes, February and March financials and capital projects update, the annual hub report, and then discuss and take appropriate action on an amendment to the contract for annual audit services. For executive committee, we have minutes and tentative schedules. And then the Board of Managers meeting, we have minutes, investments on consent, and then also approve an amendment to the contract for annual audit services. And then budget resolution updates, the Dell Medical School presentation, and the LPPF rate amendment. That is all I have.
Any questions or comments with regard to the tentative April agenda? Hearing none. Thank you, Brianna. Anything else before I move on? Brianna? No? Okay. There was no motion necessary on this item. Agenda item number 3, discuss Central Health oversight and appointments to the governing boards of affiliated entities and other entities as provided by law. As such, oversight and appointment is contemplated under law, agreement, or other governance document. Mr. Geisler?
Yes, thank you, members. Members, there is an explanatory slide deck that I'll use to help illustrate some things. And so as we pull that up for projecting this, this discussion under agenda item number 3 is really to talk about what you all would like to talk about. And we're not asking for any decisions today or for any deep deliberations, but it's really about framing 2 issues and bringing them back to the board, some of which the work is already underway. One is board oversight. Manager Kitchen, I believe you had asked a question about this at the last meeting. And the other is appointments to governing bodies. This board has recently taken action on the process, but we need to talk about the criteria that you slot into that process or plug into that process. So what I'll do is I'll frame these. Again, you can talk about this to your heart's delight, but really it's for you all to tell me, yes, you frame these properly, bring them back as more formalized agenda items and fleshed out and so forth, or go back to the drawing board and start over either way. So first, and I'm going to stand up so I can point to the board here. What this pyramid shows, and not necessarily, but in order of importance or maybe weight, is the components of what makes up board oversight. And again, this is real high level. There's a whole lot of nuances we could get into, but this just tries to answer the question at a high level. And I'm going to point to the center of this, which is board appointments and fiscal operational approvals. This right here is where you have to take action with a vote, is what you see more frequently than you do some of these other things. And also there's more gravity here to this. Obviously, who you appoint to boards has a lot to do with not only the diversity, equity, and inclusion and the skill sets, but also where is Central Health headed as an organization? And then how does this appointment reflect that? And so there's a lot, riding here on these board appointments. The fiscal and operational approvals, more recently, you all have been taking action on, for example, Sendero's budget. If there's a change in the business plan, Community Care's budget is approved. There are other approvals from Community Care that come forward to us. And then if you think about Integral Care, for example, there is, as part of the budget process, you all approve funds that are contracted, that are used to contract with Integral Care to manage inpatient hospital beds for those experiencing serious and persistent mental illness, for instance. So those are the types of operational or fiscal approvals that you make. Coming up here, I'm going to jump around this pyramid a little bit, is the foundational agreements and documents. So these you don't see very often. Now, for example, if Sendero has a change in their bylaws, I believe that needs to come back to this board, if I'm not mistaken. And so that's an example of a foundational document that you obviously would have insight into, would need to make some type of decision. I think more coming up here, Jason Fournier and I have talked about sitting down and talking about what the co-applicant agreement looks like with Community Care, for instance. And that's going to involve a whole team of staff people coming together to really pour over the documents to not only what we have today, but what is in manuals with HRSA, for example. So that's type of foundational document agreements that then we would then bring back to this board so that you all could have line of sight into that, if not approval required. Coming back down here to the lower, as you're looking at this on your left-hand side, is the ad hoc updates. This is more, you've seen with Community Care and Sendero from time to time come in and present on different items. And with Integral Care, I think at a minimum, we try to have them in here at least once a year to come talk to us about, what they're working on and what their focus is. Over here on your right-hand side, far lower right-hand corner, quarterly reports. This is something that you all have deliberated just recently, and you gave us a lot of feedback on the quarterly reports that we received for Sendero and Community Care, and those have been assigned to executive team members to take responsibility for those, and working with Sendero and Community Care to make sure that those items are now included as part of the quarterly reports, and those are going to be coming back to you in April, I believe, unless our partners say, hey, Uncle, we need a little bit more time. There's a lot going on. We're all dealing with legislative sessions and other exigencies. And so, but the goal is to have the first revised version of those quarterly reports come back to you in April. So that is the real high level overview of what constitutes oversight from the standpoint of a Central Health board member. We could go to the next slide, please. So here's the talking about what we need to talking about part. One is the forum. You'll need to decide when we bring this back, which committee will deliberate. And I like to offer a recommendation for the board's consideration, but certainly it's your prerogative. But the executive committee has tended to take, these types of things first. But that's, and it's a formed committee too. And also everybody can come to the exec. I mean, all committee meetings are open, but this is a good forum that I would recommend. I will say the more ad hoc committees you start adding, sometimes we have quorum issues. And since the executive committee is also meeting, if you all will bear with us and humor us, if we could just tack one more thing onto the agenda, it makes it a lot more efficient to be able to process those meetings. And also we're less likely to have quorum risks and schedule them, have to reschedule meetings. The second thing that you need to deliberate is determine what issues will be deliberated and ultimately what will be presented to the full board and action. So when you start thinking about oversight, and again, I'll draw on the example more recently with looking at the quarterly reports from Community Care and Sendero, where you all went through those, you saw what what we presented to you in the past, and you said, we would like to see this, this, and this, and you all came together as a board and provided that guidance. And so we're going to go turn around and go do. It's almost the same thing. You need to start thinking about, with what you saw on that previous chart, what is the purpose of the oversight? And you can go to those foundational documents. You can go to those ad hoc reports that you've seen. You can think about the types of approvals that you have coming into you or the types of appointments, and really start trying to put some definition around what that oversight is. I bet we could go around the room today and receive, probably get 9 slightly different answers on what that means. And so you need to come together in terms of what that means, because that's important for us as staff so that we can execute on your behalf. Again, these are just some examples. I won't go over all of those. I think they're fairly self-evident. But then also, as part of this deliberation, you need to allow for subject matter experts to provide information and respond to questions. Those of us that might understand governance systems, we might be a subject matter expert, but you might also need to hear from the chief medical officer, the chief strategy officer, legal counsel. You might need to hear from Stephanie, just because she comes up and presents a lot. So I think that allow for those subject matter experts to come in and answer your questions and assist you with understanding what is it that is going to make up oversight. Another way that I like to think of the scope of the deliberations, if you can go back to the prior slide and show the pyramid real quick, that second bullet point really gets to, is this pyramid sufficient? Is there something here that needs to be changed about this? Something very fundamental. And so that second bullet point will actually affect what this looks like. So if we can go to the next slide, back to the next slide. And then timeline is really TBD. So that's the oversight issue. Before we get into the board appointments process, does that, I realize you're just seeing this information, but it was contemplating the agenda form that this is what would be presented, but is this a sort of framing that you would like to come back to and pursue as a deliberation guide?
Okay, thanks, Mike. Manager Kitchen, any comments?
Okay. Yes, I think so. I think that the purpose of oversight is the key thing to key in on. And from my perspective, it's about, at a high level, it's about carrying out the mission. Because I see these entities, most particularly Sendero, as carrying out a function, one of central health functions, essentially. We have a mission and a goal, and various aspects to that. Right. And we want these entities to be aligned with that. Now, be aligned with that to the extent that they are doing the work that relates to central health. In my mind, Sendero is everything Sendero is doing should be aligned with central health. I can see that community care would also, I think, I'm not as familiar with them. Integral care would have overlapping. They are carrying out functions that relate to central health. They also have functions that don't relate to central health. So regardless, I think that the purpose of oversight has to align with, we have to oversee these entities to a degree to be assured that they are carrying out and aligned with the purposes of central health. That's pretty high level. You have to,
Sure.
The question really, that doesn't really say much.
But if we brought this back to, you feel like you've got the latitude to have, that the board would have the latitude to have that type of discussion. I mean, that's.
Yeah, I think
okay.
so. I think I think all of these things that you've mentioned would be within the scope of what would need to be discussed. I might drill down a little bit in purpose of oversight, proper role of the board, and proper role of the board needs to go down to, from a financial perspective, you know, what is our role in terms of overseeing finance? So I think that term proper role encompasses that. I would just want to make sure that that was included. So
Okay.
that's in general what I would say.
Thank you. And just for clarification, integral care is not under our oversight, so.
Well, but it's listed, we don't oversee them, but we do,
Appointment to the.
we
board.
do appoint.
That's
So
correct.
you're right. So oversight's, so with integral care, it's a different type of relationship,
Mhm.
but there still needs to be some relationship.
Relationship, and I guess my question is that we would be able to direct the person that we appoint.
Right, that's what I mean.
As to what their role would be in carrying out the furthering of our mission and aligning that with what integral.
That's
care
much
is.
better said. That's really what I meant.
Okay,
So,
I just wanted to clarify.
yeah.
Thanks.
Yeah. Mhm.
Manager Montgomery.
Agreed, and defer to the chair on the forum.
Okay. Manager Prince.
I'm not sure this.
It would be also beneficial, at least for me, if we had a clearer understanding of the roles of our own little subboards. You know, we have our, you know, the Budget and Finance Board or the Strategic Planning Board. And yet I feel committees, yes, sorry, committees. I feel that that we may want to be more explicit about the importance of those and how we come back to the board and share our decision making.
Okay. I think that would be, when we look at the bylaws actually outline for us what our roles are in our committees and where our responsibilities are. If we want to relook at those areas and then talk about that, that would be sort of a different agenda item. Correct me if I'm wrong, folks.
Well, we can fashion the agenda item however is necessary to jump into whatever you wanted to. I think with each, to talk about bylaws in general, if I'm tracking the conversation, if you wanted to focus on a specific set of bylaws, you would need that for that organization separately.
Sure. And I'm just saying that those roles are outlined in the bylaws. And so
Correct.
It's, we either look at those and clarify them, change them, if what I'm hearing you say is correct. Okay. Manager, Manager Musai to.
I was wondering if it's appropriate in the next couple months or so to have or hold a retreat to discuss this a little bit further amongst us.
If we can find a time where everybody can come, we surely will try to put that
I think
together.
there's a lot now to discuss as a board.
Mhm. And I know Manager Jones has requested that for a number of times. Manager Valadez.
Yes, I have a couple of things to say.
Please. Thank you.
Thank you. With respect to our oversight of the various committees and the appointments that we make for those boards, I think it's important for us to make sure that we understand that perspective means a lot. Lived experiences mean a lot. And I'm still bothered by a comment that was made during the last discussion that we had, where I was told with respect to a Sendero appointment that we had already reviewed the candidates and had someone that fit that bill. Well, I looked at the board members for Sendero, and I have to say that we have a Latina that applied, who was a lawyer and had served under you at the Department of Insurance. Yes, and was very well. I guess she had sufficient, very well qualified. I was told that because there was someone else, we were not going to consider that. I'm one person who has always looked at the demographics of the board And how many times have anybody who's sat here anytime for any period of time heard me say that our board members, just like our staff, should be representative of our population, the population that we serve, our demographics. And those are things that we need to consider when looking at making these appointments. And because that perspective is going to determine what they will do as they review whatever they're having to deal with in their agendas on their individual boards. You talk about strategies, you talk about methodology, you talk about how are we going to outreach, et cetera, educate, et cetera, based on the various populations and demographics. So I think that's very important. And I don't see that here, but I want everybody to
Well,
understand
actually,
that that's
it's
where
on
I
the
come
next,
from.
it's on the next slide. When we get to board appointments, and if you'll look in your packet, there's a memo there from September 2nd of 2022 that it's a set of informal criteria that speaks directly to
Right,
diversity,
but
equity, and inclusion
I
as
appreciate that.
fundamental to live. So
Yeah,
but we will certainly get to that,
equity, inclusion. Well, I want to make sure that we as a board,
but also service in the.
we as a board understand what that means.
Mhm.
And that doesn't happen in a vacuum. That happens because we have had those experiences, or we bring our personal opinions to the table in the hopes that others will understand and listen to them.
Mhm.
So I just want to make sure I said that, because that is important to me.
And I think that's not only does that apply here, but it carries forward to this discussion here around board appointments
That's
directly
right.
that we're about to get into.
And with respect
Right.
to Manager Brinson's concern about what each committee is supposed to do, and we look at it in our bylaws, then I'm supposed to be the chair of the bylaws committee, and I'm going to call a meeting so that we can discuss that at length, especially with respect to our missions, alignment of our missions, and how it is determined by board members who set policy and who direct CEOs or administrative directors to get their staffs to get on board, to make sure that we're accomplishing that at the bottom end, at the ground level. So thank you.
very much. Manager, Manager Jones.
I'd like to piggyback off of what Manager Kitchen had said a while ago. I think one of the challenges we have in the structure we have as a healthcare district, unlike other major healthcare hospital districts across the state, is that we are more of a confederation as opposed to a agency, or should I say a complete district. And so when we appoint people to these boards, in essence, they reflect us, but they are only part of what goes into the decision of that agency to do what it needs to do. Until we, this is my opinion, come to grips as to how we're going to function as a board from the community point of view, we're going to always have that challenge. And so I've been one who said that we need to revisit with the public what we are, because most of the public see Central Health as the hospital district, but in reality, we're not really a hospital district. We're more of a healthcare district that has a hospital through another arrangement, other services. We need to do more about that to help the public understand until such time we decide that we're going to be a hospital district. And so when we make appointments, I think we should ask those appointees to go forth, take our direction, and report back to us on a frequency of what they're doing to achieve what we wanted us to do and what those agencies are doing consistent with what we want to do. Until we have that kind of communication, we're going to continue to have this sort of fractured type of structure.
Thank you. Manager Martin.
Thank you.
To second, I would agree with you. And I think that in light of the fractured structure, I think that everything that can be structured away for efficiency would be immensely beneficial. So because we are so fractured in that way.
Thank you.
Thank you, Manager Martin.
So then what this is, first of all, thank you very much for this feedback. I think, I've taken some notes here, so we'll go back, we'll reframe this, we'll bring it back as an agenda item, make sure you've got time, talk about the how you want to structure some of the committee meetings around this, but this makes sure that we're on the right track. So this is very helpful. Thank you. Members, the next section, and I'll move through it quickly, gets to what Manager Valadez was speaking to, which is board appointments to other governing bodies. You've got a couple of backup items in there. One is a September memo that I mentioned that's was a set of informal criteria for the board to consider when making appointments from last year. And then another is a memo that talked about process, but more important is that it laid out some of the appointments to the other entities. That's not an exhaustive list. There are others. So for example, there's the Affordability Council that recently communicated with us from Councilmember Fuentes' committee to say, hey, we need an appointment. It hasn't met in a while, but Sherry Greenberg was the appointee to that. And so they need it relatively quickly. So we didn't bring it back to you today, but because we wanted to follow the processes that you all put in place. But that's another example of an appointee that's not an enterprise or a funded appointee, if you will, or a funded agency, but it's still an important appointment. So I didn't want to gloss over that. It's not just about community care, dental, and integral care. So on that, again, if you'll go to right here is just a quick timeline. I mean, you've all have worked on this before. And really, I think you're at a space right now. If I go down this next right here, it's really about refining the criteria. You all have done the work. You've had the conversations, and you're not that far off. So you're not starting with a blank slate by any means. If we can go to the next slide. So again, this is about framing this and bringing it back to the proper committee. You'll need to decide which committee, takes the recommendations for the board for adoption to say, this is what we recommend as the criteria that we use when placing board appointments. Again, you can create an ad hoc or executive committee. My recommendation is the executive committee because that's an established committee and for the aforementioned reasons, and trying to avoid quorum issues. You do have the ad hoc committee that's put together for actually the appointments process is another place that you could put that. But again, it's totally up to the board's call on this one. The scope of this, you have to think about what your frame of reference is. And again, I mentioned some of those memos that you've got in your packet. So you do have a starting point of reference, if you will. You don't have to go, start over whole cloth. Really, I would say this one does have a little bit of timeline to it because with appointments coming up, I just mentioned one that probably needs to be made sometime in May or June, even though it's a little bit behind schedule. I think that's okay. It'll still function. But as you start to think about marrying that up with what you just saw on the oversight piece, it would be really good if you could have that criteria in there to match it so that you've got something to work with as you're thinking about what your oversight looks like. And also with this, and I don't have the list in front of me of which appointees are coming up, but that'll be here before you know it, usually in the fall. And so having this in place so that we can be provided to individuals and, would certainly be helpful. So that there's a little bit of flexibility in that May timeline, but I wouldn't recommend going too far past that. So if this fits with what you're thinking, we bring it back. Chair Bell, you'll need to decide, does it come back to the executive committee? Do you want to, create an ad hoc committee or send it to the ad hoc committee that was created recently? And then we'll pull together the materials, and then you all just need to have deliberations using a reference point where you say, I agree with this, I don't agree with this, or we need to include this. And so that we can start adding and subtracting and amending as necessary to come up with a criteria that, meets the board's wishes on this.
Thank you, Mr. Giesland. Hold on, Manager Valadez, I see your hand. I do believe that as we talk about governance, that should be in the executive committee, but the refining the criteria for the board appointments and making the board appointments recommending the board appointments is really a function of the ad hoc committee. And so, because if you pile too much on the executive committee, we just can't ever get to the board meeting.
Yes, sir.
And so, in essence, we need to sort of form out some of this. So that's my thought.
So bring it to the ad hoc.
Right. All right, Manager Valadez.
I was just going to ask you if you could provide us with a copy of that.
Certainly.
Thank you.
Manager Martin.
This is
think that. Think in terms of say. Is it in light of the efficiencies needed, as you state, to sort of make the executive committee work? If there can be some criteria met, say for diversity questions that general committee can submit a set of questions that then the ad hoc can then review and interview a person, as we did like the first time I was here, so that then those issues have been addressed in a way that everyone feels comfortable they've been addressed, and they can submit, the committee can then submit the recommendation to us, and we can vote more quickly, as long as the criteria have been met that we all sort of agree on.
Agree. I totally agree with you. Manager Kitchen, I'm sorry, did I see your hand? No, okay. Any other questions? Okay, thank you, Mike.
Thank you.
I think you have
Appreciate the
enough,
guidance.
and
Yes, thank you. That's
You
helps.
and I can work together to
Yes.
frame the discussion for next time. Okay, members, we'll go on to agenda item number 4, as requested by the administrator, discuss and deliberate the board's oversight responsibilities of the administrator of Central Health and the administrator's appointment, employment duties, and roles within Central Health. I announced that the committee is convening in closed session to discuss agenda item number 4 under Texas Government Code, section 551.074, personnel matters. The time is 5:58 p.m. and it is Wednesday, March the 29th. We are back in open session. It is Wednesday. Are you hearing me? No. We are back. Okay. Testing. Can you hear me? Ask any of the members of. Okay. Okay. We are back in open session. It is March 29th, 6:40 p.m. There was no motion necessary on agenda item number 4. Agenda item number 5, confirm the next regular executive committee meeting date, time and location. Managers, our next Central Health Executive Committee meeting is tentatively scheduled for Wednesday, April the 26th, 2023 at 4 p.m. or immediately after the Budget and Finance committee meeting at Central Health Administrative Offices at 1111 East Cesar Chavez Street, Austin, Texas, 78702. At this time, I'm ready to accept a motion for adjournment. And second, I have a motion for Manager Musaitis. I have a second from Manager Valadez. Any further discussion? All in favor? Aye. Any opposed? Any abstaining? We are adjourned. Okay, members, we'll go right into the board meeting. Good evening. Today is March the 29th, 2023, and it is 6:41 p.m. As a quorum of the board is in attendance, I'd like to call to order the meeting of the Central Health Board of Managers. The first item of business will be the consent agenda. Consent agenda C1, approve the minutes of the Central Health Board of Managers, February 22nd, 2023 meeting. Consent agenda 2, receive the quarterly investment report and ratify Central Health investments for February 2023. Consent agenda item 3, approve the process for interviewing candidates for external appointments, including approval of the formation and functions of an ad hoc appointments committee created by the board chair as recommended by the executive committee. And consent agenda 4, approve notice of intent to issue certificates of obligation to finance acquisition and construction on or renovation of real property and related reimbursement resolution as recommended by the Budget and Finance Committee. Manager Valadez.
Well, I don't have a copy of that, any of that, so what I will do is I will move to accept or adopt whatever was stated by our. Oh, I thought I needed to say everything. I don't need to repeat it.
No, you don't need to.
Okay, then I move the adoption of our consent agenda items C1 through C4.
I have a motion. Do I have a second? I have a motion from Manager Valdez. I have a second from Manager Brinson. Any further discussion? Hearing none, all in favor? Any opposed? Any abstaining? Motion carries. Okay, we will now proceed to the regular agenda. Members, we are not taking up posted item number 4 this evening. That item was receive and discuss updates on the 1115 Medicaid waiver, the Community Care Collaborative, and other healthcare delivery partners, programs, projects, reporting, and arrangements, including agreements with Ascension, Texas, and the University of Texas at Austin. At this time, I will entertain a motion to limit debate to 3 minutes per member per item for all items in the regular agenda of our meeting this evening. I have a motion, Manager Brinson. I have a motion from Manager Brinson to limit debate on all items on the agenda to 3 minutes per member per item. I have a second from Manager Jones. Any further discussion? All in favor?
Aye.
Any opposed? Any abstaining? Motion carries. I now announce that the board is convening in closed session to discuss agenda items 1, 2, and 3 under the Texas Government Code section 551.071, consultation with attorney. Item 1 will be discussed in closed session only to the extent that there is a connection between legislation and pending legislation, and attorney-client advice is sought on those related issues. It is March the 29th at 6:44 p.m. Appropriate action on an update from a legislative and government affairs staff and advisors on the current legislative session. Agenda item number 2, receive and discuss a briefing regarding Travis County Healthcare District doing business as Central Health versus Ascension, Texas, FKA Seton Healthcare Family, cause number D1GN 2300398. And agenda item number 3, to receive and discuss a briefing regarding Birch et al. V. Travis County Healthcare District doing business as Central Health and Mike Giesland, cause number D1GN 17005824 in the 345th District Court of Travis County. Thank you. Yeah.
Great, thank you. Okay, we are out of closed session. It is March 29th at 7:49 p.m. There was no motion necessary.
We are out of closed session. It is Wednesday, March the 29th at 7:49 p.m. There were no motions required on any of the items that we discussed in closed session. Agenda item number 5 is to confirm the next regular board meeting date, time, and location. Managers, our next Central Health Board of Managers meeting is tentatively scheduled for Wednesday, April the 26th, 2023 at 4 p.m. or immediately following the executive committee meeting at Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. At this time, I'm ready to accept a motion for adjournment. Manager Brinson.
I move that we adjourn.
Manager Motwani.
Second.
I have a motion from Manager Brinson, a second from Manager Motwani. Any further discussion? All in favor? Any opposed? Any abstaining? We are adjourned. Thank you very much.